Hi, everybody. It's Sister Light of Christ and our special guest panelists this evening, Justin Alves, RN, ACRN, CARN. That stands for Registered Nurse, AIDS Certified Registered Nurse, and Certified Addiction Registered Nurse. At the end of the day, they're a registered nurse.
Exactly.
And we're here this evening to talk to you about meth. So buckle in, folks. Before we get started, could you tell me sort of a little bit about who you are and how you decided you wanted to be a registered nurse and how you got all those extra words tagged on to the end of your registry?
By accident, that's what I tell everybody always. I went to nursing school. My plan was to be a nurse anesthetist and to put people to sleep and never talk to them. And I had a professor who told me that I had to volunteer at the needle exchange when I was in nursing school, or she was going to fail me. And so I went to the needle exchange and I realized that the folks I was seeing really needed help and really needed me. And then when I graduated from nursing school, I started working on this van that did HIV testing. I diagnosed my first patient with HIV, and then I was in it. I couldn't turn back. I was these are my people. I'm supposed to be here. I'm supposed to be doing this work. And so I became an AIDS certified registered nurse. And then quickly in my work as an HIV nurse, I realized my patients with addiction really needed an advocate. And so that's where the addiction piece came in.
Wow. So you might say that this is a calling.
Yeah, I don't know if it's a calling or a voice in my head. My professor was the one that really and truly, she will say to this day, when she met me, she knew I wasn't supposed to be a nurse anesthetist. She knew way more about me than I knew about me at the point. And I was just fortunate enough to meet her at the right time and run into her.
Mm. And what is your home hospital?
My home hospital, so I work at Boston Medical Center, and I work as an addiction nurse educator right now. And I go throughout the state, through other parts of the country, and I teach about addiction, opioid addiction, methamphetamine addiction, alcohol addiction, whatever it might be.
Do you think that there has been a uptick in the last year, 5 years, 10 years? Has there been a movement towards people self-medicating with these unregulated drugs?
Yes, 100%. So we've actually seen, I think everybody always calls it the opioid epidemic, and that is a total misnomer. It's not an opioid epidemic, it's a drug overdose epidemic. We know nobody is just using opioids. If I could find somebody who is just using heroin, right, that would actually be really easy. We have really great medicines to treat somebody who's just using heroin. We don't if you're using heroin, a little meth, some coke, drinking a little bit of a 40, right? It becomes more complicated. I mean, I think especially in COVID, we've started to see sort of this swing where there's people using more substances, which is historically pretty in line with what we've seen with other horrible disasters, Katrina, 9/11, other pandemics.
What do you think it is about the circumstances that we're finding ourselves in right now that might be opening the door to folks who previously didn't have a drug use habit or an abuse? What is it that is causing people to turn to these coping mechanisms?
Well, I think there's I always think of substance use disorders. There's three buckets of things that lead to the development of a substance use disorder. There's your genes that we can't change, and everybody has those. So there's a whole bunch of folks who are susceptible to developing one. Then there's these two other things called the intermediate phenotype, so sort of your brain and how it works, and then your environment and how your environment and your brain develop are hugely important. So I think in COVID, the social isolation factor of it all really ups the ante on people having a drug problem and using more frequently and then having a substance use disorder.
how does this start? How does somebody just wake up? Let me simplify that. Have you found a common thread um, in people's narratives when they get to you? By the point that they are at your office or your doorstep, is there a common narrative or
Yeah.
shared experience?
I think trauma is the gateway drug. I think what we know is adverse childhood events, these bad things that happen to us when we're little, right? Everybody has them. Bambi's mom got killed, right, in the movie, right? Everybody has bad stuff that happens to them, but it's how people respond to the bad stuff that leads to a substance use disorder, or I'm going to plug my own t-shirt here, resiliency skills, the ability to like have bad things happen and then get over it, right? And for some folks, that the way you get over the bad stuff is by coping with substances.
Now, is that a shirt that you just happen to be wearing, or is it actually a Justin Alves shirt?
It's not. It's actually a shameless Boston Medical Center plug. And so this was a shirt that a lot of us at the hospital got post-COVID, right? COVID was this horrible experience for all of us. It still is this horrible experience for all of us. And I think we're all coping with it by taking care of the folks that we see every day as best we can. And I think, but the same is true. We do that at Boston Medical Center all the time for those folks, right? Everybody talks about the folks on Mass Ave and Milnia Cass. Like, those are my patients, right? Like, I love them. I want to take care of them. And it kills me that they're out living on the street like that. That's not a place anybody should have to be. And I think the hospital understands that the goal is to get people to be resilient, right? To pull them out of their chronic disease, their really severe episode of a chronic disease, and get them to a place where they're like substantive and a person again, and feeling like they're a person again.
I would be remiss if we didn't give a huge shout out and thank you to Boston Medical Center this evening, who we're very excited that they're on board with this educational content. And so I'm grateful to them and to you for making yourselves available to us as resources.
Absolutely.
So,
happy to do it. Happy to be here.
what do you think it is about these substances? So let's talk about meth first, and then we can go to opiates. Why would somebody do meth? Why would they get into it and be like, this is great?
Yeah. Well, so meth is the happy drug. Meth is an upper. It releases a bunch of dopamine. It makes you feel 2,000 times happier than the best orgasm you've ever had in your life. That's how much dopamine you get in your brain, right? There's literally nothing like it in the world that can be compared to it. So once people do it a couple times, it becomes very habit forming because it feels really good and people want that experience again. The question is, why do people try meth the first time? Right? And so there's lots of different reasons. For what we're seeing now, and some of our patients who are homeless and regularly using other substances, they're turning to methamphetamine because it's cheaper and it gets you to have that sense of euphoria faster and for a longer period of time than does cocaine, right? Which is fairly expensive. With what has traditionally been sort of the model in New England is it's been men who have sex with men, and they're not always out, right? There's several folks who are sort of like on the DL who might be using substances and who don't know what Tina is, right? I smoked Tina the other night. I didn't know Tina was meth, right? If you say, do you want to smoke meth? Nobody goes, yeah, that's a great idea if they've never tried it before, right? People know meth is bad. It's the scenario and the scene in which you're offered the drug that is oftentimes tantalizing to people.
And you had said men who have sex with men, or MS. So I suspect that part of that too might be the allure of intimacy or wanting to have that. I think as queer folk, but specifically gay men, we're still, at least our generation sometimes is still hungering for what we consider genuine connection and don't know how to, obtain that. And so, correct me if I'm wrong, once you develop the habit, what becomes hard is that it anchors into so many parts of identity. Does that seem to, would that be an accurate statement?
Yeah, I mean, dopamine is a chemical that we all need, right? It's in our bodies. We need it every day. It happens every day. It's when you use meth, you have this overwhelming amount of dopamine in your body, and it affects everything you do, right? It's a multimodal drug. It's going to affect a whole lot of different things. The way you sleep, the way you eat, the way you have sex, right? It makes you hypersexual, which is why for some folks who have issues with their sexuality, right? Many folks who we see either they come out later in life or they're young, right? They're like 18 or less than that on Grindr, where they're not supposed to be trying to figure stuff out. And that's where we see these new sort of initiates of methamphetamine use. So there needs to be a better part on the medical community side to do more prevention stuff, right? To say like the capital T in the Grindr profile means meth, right? That you need to know that, right? Because I think some people don't know that, and providers don't know that, right? The pediatricians don't know that, right? And so trying to say like this needs to be part of your practice if you're taking care of folks is on us to try and figure out how to do.
Now you had said that it's a longer high. How does the body process this chemical? And is there, let's say I was high on meth, does that stay contained just to me, or can I expose somebody else to the chemicals that are in my body by interacting with them in different levels of intimacy?
So meth is actually really poor. This is a great question. So meth is actually really poorly metabolized in the body. About 86% of methamphetamine that goes into you is going to come out actually as methamphetamine. And so that's why when we do drug tests for meth, right, like if it's delta methamphetamine positive, like that person definitely did meth, right? Like there's no like, oh, maybe I didn't do meth, right? Like, no, you did. So could somebody be exposed to methamphetamine who didn't do it themselves, but was maybe exposed to urine? Yes. The short answer is yes. There's a really funny YouTube video about it. The comic's name is Jessa, and she was addicted to methamphetamine urine at one point, and she has a really funny skit about it. But it sort of drives the point home of sometimes these weird exposure methods are how people develop a substance use disorder.
Right, because you're saying, I could see someone saying, well, I don't smoke it, so I don't have a problem. Here would be another question. Is there such a thing as recreational use? I've heard that batted around by very professional, successful people, some of them in the medical industry, that oh, it's just recreational. And I'm like, what? So is there a casual meth user?
So this is a great question, because I think when we talk about what defines a substance use disorder, the DSM has some very, very clear guidelines about what defines it, right? So there's the traditional things we think about of like withdrawal and tolerance, and you need more to feel higher, or if you don't have it, you feel sick, right? That's what everybody associates with addiction, but it's actually a lot more than that. It's doing things that may have harmful consequences, knowing that consequences might be harmful and doing them anyways, right? That's a huge part of what addiction is. And so many of the folks that you're describing, who might be doctors or lawyers or have big fancy jobs, but party meaning use drugs and have sex from Thursday to Sunday every week, I would argue that that's an addiction. That's not casual use, right? Especially because the half-life of methamphetamine, the true withdrawal period for methamphetamine, is between like 7 to 10 days is where we see peak meth withdrawal. So if you only use it on the weekends, you actually never reach peak meth withdrawal before you start to use again, which I think a lot of people don't understand. And then like they might miss a weekend because they like had to work, and they're like, I don't know why I'm so depressed on Monday. Well, it's because you didn't use meth, and that's actually a withdrawal symptom. Suicidality, wanting to kill yourself, is a symptom of stopping using meth.
So it sounds, I'm trying to not come off judgmental. It sounds like a really nasty drug, like with high allure points, right? Because once you're in there, you're in there. But it sounds to me like it has multiple barbed fingers, and once it's in you, getting out of it is, sorry, go ahead.
I think no, but I think that that's a great point. So part of what I do for my job is I try to make meth less scary, right? And so I know I just spent this whole time like talking about all the horrible things that meth is, but we can treat meth, right? And not everyone thinks that. So SAMHSA, which is a national organization, the Substance Abuse Mental Health Services Administration, the only thing listed on their website right now for resources for methamphetamine users is a YouTube video where an animatronic monster sucks out someone's soul. Okay, not helpful. Just not helpful. I don't know how else to say that, but it's not a helpful video. All it does is scare people, right? It's this is your brain on drugs video to like the nth degree. The reality is we have some really good treatments for meth, and we need addiction providers to start ponying up and sort of using them and saying, no, like we will take care of you. Come to clinic. We want to see you. We want to be able to help you. Don't just sit at home and wait for something bad to happen, because that is what a lot of our patients end up doing.
How do you, so actually let me break this down. Do you think meth kills people?
Meth definitely kills people
How?
eventually. There's lots of different ways. So methamphetamine overdose is a very real thing, right? And we know that that's on the rise in Massachusetts. We've seen a 400% increase in psychostimulant overdose deaths since 2000 in the state of Massachusetts. That is on par with what we've seen with opioids, but nobody talks about it, right? And so I think that that's a big problem, A. B is the way people overdose on meth is not as simple as stopping breathing and turning blue, right? They might become hyperthermic, meaning their body gets really, really hot and they have a seizure. They might have a heart attack. They might have a stroke. They might have some other thromboembolic event, so they like throw a clot somewhere. There's lots of things that can happen. But I think the other thing that we see is this huge increase of infectious diseases. And let's say you're a young person or you're somebody who's like, in the closet and you're using meth. You might not be getting tested regularly for HIV because you're worried about what someone might think. And so then we see these folks who, have been using meth for 3 to 4 years, but they present with like AIDS diagnoses, right? Like PCP pneumonia, cryptococcus meningitis. I saw somebody with toxoplasmosis last year. Like there's all these diseases that many folks in the HIV world who are like on the prevention center are like, no, people don't get that sick anymore. It's like, no, they do. But it's these folks who are using substances that usually are afraid to come in because they're afraid of what the medical people are going to say to them.
So let's just take a little tack for a moment and let's circle into opiates. What are they?
So there's opiates and there's opioids, 2 different types.
Okay.
So opioids are like the better term. I would use the term opioids because it encompasses synthetics like fentanyl and methadone and buprenorphine, and the naturally occurring opiates like heroin and codeine. So opioids is it's like the whole like all squares are rectangles, but not all rectangles are squares. So all of those things are opioids, but they're not all opiates.
What do they do?
They slow everything down, essentially. They like slow your breathing, they slow your gut motility, they make pain sensation go slower. So essentially you get better pain control. You get analgesia from it. You feel better, pain relief.
So is Xanax an opioid?
Xanax is actually a benzodiazepine, but also a downer. And so what we see sometimes is people who use uppers like stimulants, like meth, when they're trying to come down, like let's say you partied all weekend in P-Town from Thursday to Sunday, you were up every night, like you were smoking Tina and having sex, and then you have to go back to work in the office on Monday. Well, I might take some Xanax or maybe an opioid, which are downers, that are going to help make that transition back to my normal life a little bit easier.
You know, I'm not a medical professional, but I would imagine that in the scenario you just painted, alcohol is probably also present, which you had already mentioned that in the beginning of our talk. I could see that might cause an exacerbated problem that somebody did not necessarily plan. Like, I did not plan to stop breathing, but
yeah. Well, I mean, alcohol is like one of those things that nobody talks about, right? But like we know more, like over 200 people a day in the US die from some alcohol related cause. That's more than opioids. Like, I don't know why we're not talking about that more. And there's tons of sequelae. I think the other thing about alcohol that's kind of interesting is there's this whole stigma about other drugs. And even how you said, like, it's a nasty drug, I don't know why people use it, blah, blah, blah. Alcohol does horrible things to people too, right? And yet we have safe consumption sites, we have bar rooms that people can go in and drink and be monitored. And if you get too intoxicated, somebody tells you to go home, right? And so I think we split hairs sometimes when we talk about harm reduction with some of these other things because they're different, right? They make us all feel different, and there's a stigma associated with them that we don't necessarily have about alcohol.
right. That's a lot to wrap my head around, and I'm sure later on tonight when I'm, you know, reposed in my bed, I'm gonna be just like thinking about it. What are the, how do opioids work?
So they essentially attach to receptors in your body, and they give you that pain relief, what some people would call the high, and they slow other parts of your sort of mobility down. They attach to these things called mu opioid receptors, right? And so the way the treatment for opioids works is Suboxone or buprenorphine and methadone attached to those same receptors, but they do it in such a way that if you put enough Suboxone or methadone in your body, even if you use heroin or fentanyl, it doesn't do a good job of getting on the receptor. So people don't overdose because even if they relapse, even if they use while they're on Suboxone or methadone, they can't get those other short-acting opioids can't get to the receptor to cause people to stop breathing. We don't have that for meth. That is a huge problem. We don't have medicines. We don't have a pill that helps people with meth because there's no pill that we could give you that would like stop your dopamine release because that would cause other problems. Like we need dopamine, like I said. And so I think that that's part of the real struggle with meth is that we don't have a medicine like we have for opioids.
So how does opioids kill?
So opioids kill people in almost the exact opposite way that meth or cocaine would. They slow everything down and they stop people from breathing. So your breathing becomes so shallow, you're breathing maybe once, maybe twice a minute, maybe not at all. And that lack of breathing obviously causes people to die because they have respiratory depression. They can't get oxygen throughout the rest of their body. So Narcan, nasal naloxone, if you give that to folks who aren't breathing, it makes them breathe again. It's that simple. That's all it does. It's the only purpose of that medicine is to reverse opioid overdose. And so we also don't have that for meth, right? And so if somebody starts to have a meth-induced psychosis or a meth-induced heart attack, there's no anti-meth drug that like takes it out of your body and makes the heart attack stop.
You're just on the ride until you're not.
Right. And I think one of the other things that we see is with people who are using meth and opioids together, let's say they overdose on fentanyl and we give them Narcan so that they can breathe, nasal naloxone so they can breathe. Then the meth sort of is really heavily in their system still. And then sometimes folks have a heart attack because now the opioid is gone that was sort of slowing the heart rate enough that the person didn't have a heart attack or didn't have a stroke. So that's why the mixing of substances is really hard for medical teams to deal with.
Is that something that, let's say somebody came in emergent, is that something that you can, I'm going to use my Grey's Anatomy terms, can you talk screen, or is that the right thing? Can you figure out, like, live in the moment, what's in them, what's happening to them, and like how best to help them? Or do you just kind of do the practice of medicine and hope that taking one thing away isn't going to start a chain reaction of other things?
I think we talk about it as like Maslow's hierarchy of needs, right? Like when you come into the emergency room, you're coming in because there is an emergency. I'm going to deal with the emergency I see because that's the one I know exists. So if you're not breathing, I have to get you breathing. And so we've done a really good job, I think, at our hospital and around our hospital to say, not everybody needs 10 milligrams of Narcan to bring them back, right? They might only need one spray in the nose, and then they start breathing again. They may still be a little somnolent, a little sleepy, but I don't need to give you any more because you're breathing, right? My job is done. You're breathing. Great. I'm going to watch you. Keep breathing.
Right.
There was this old mentality of, well, no, you need to not just be breathing. You need to be like, the opioids need to be out of your system in time. And that's how we got into trouble, because we had changed acute processes so quickly that people had these like sort of bad reactions.
So correct me if I'm wrong. So this, some sisters, we get training in Narcan. So when I was in California at a conference, that's when I was trained in deployment of Narcan. So the first thing we learned was how aggressive Narcan actually is to the body of somebody who is either overdosed or like on the edge but still safe. And so you have to get up and close and like try to rouse them and be like, are you like, really make sure they're not breathing before you do it, because it pushes the body goes from high to what is that word?
Withdrawal.
Yeah, you like slam them right into withdrawal, which is a caustic and traumatic experience.
Yes, it totally is. And so what we do at BFC and what we teach people to do is this thing called verbal Narcan. So before you give anybody Narcan, I always do a sternal rub or right here on the top of the lip because it hurts. You want to do something that hurts. And then you say, hey, buddy, gal, whatever, I'm going to give you Narcan now. I'm worried that you're not breathing. Folks who are using opioids and breathing, but just like really high or really intoxicated, are going to respond to you and say, don't give me Narcan, and walk away from you. If they can walk and talk and breathe, they don't need Narcan. Right? And so that's always what I tell people is like, always go with your gut. If the person, just say you're going to Narcan them. If they don't say anything, that's usually a pretty good sign that they actually need the Narcan.
So in Massachusetts, can general public carry Narcan?
Yes. And you can actually get it at a pharmacy. So Dr. Alex, I'm going to plug a BMC doctor here. Dr. Alex Wally wrote a prescription years ago. Before I even knew him, I was picking up Narcan under a prescription under his name at one of the pharmacies. So there's a standing order from Alex to be able to pick up Narcan at pharmacies in Massachusetts for anybody. And they just run it through your insurance like anybody else.
Do you say his name when you go to the pharmacy?
No, you just go to the pharmacy and you can just say, I need nasal naloxone, and they're going to give it to you under this standing order.
Now, what are the legal ramifications if Joe Schmo or Betsy, whoever, on the street administers Narcan to a person? Are we potentially at risk? Could we get sued? Could something happen? Like if the patient dies or if the patient has something happens, What are Massachusetts rules?
So in Massachusetts, the Good Samaritan law is going to protect you. So the Good Samaritan law means you were doing your best. You thought that was going to help, and it was an emergency, and you were somebody, and that's okay. In COVID times, normally we tell people if you're going to give Narcan, you need to rescue breathe and breathe in the person's mouth, right? Or use an ambu bag to help them breathe. You put that mask on them and squeeze the thing. But in COVID times, that actually can aerosolize COVID, or you could get exposed to COVID on someone's mouth. So we recommend using an ambu bag, but one with a filter, or just give the Narcan and try and either give rescue breaths through some sort of a device so you're not going to be exposed to the COVID, like some sort of plastic or some sort of a face mask if you can. Breathe through it.
Let's say I know somebody who is in addiction or is in it. How can I help them or no? Like what do I do?
I think we can always help.
Okay.
Yeah, I think we can always help. And I think the question is, what does the person need or want? And there are some people who are ambivalent about their choices and about their substance use because their life is just so terrible. I think the biggest thing we can do for folks who are in the community who are not currently connected to care is to try and get them into care, right? So at Boston Medical Center, like, you can call us, we will get you an appointment. You will see one of our nurses in the OBAT clinic. We have a nurse care manager model at Boston Medical Center for our addiction program, which means most of your visits are actually with a nurse. They're not with a provider, right? They're not with an NP. They're not with a doc. You're seeing a nurse who like knows addiction, which I think really is so powerful in so many ways because nurses have this trusting bond with all the patients. Like the reason why I do this work is because I love my patients, right? I love everything they teach me. I love everything I can do to help them. And I want to see you I actually want to see you more when you're using, not less, right? Because I'm more worried about you when you're in active use, when you're actively shooting up crystal meth or you're actively snorting heroin. That's when I need to see you. Right? If your life is going great and like you're taking your Suboxone or you're like going to meetings, like I love to see you because that makes me feel good. And like I go like, oh, good, look at me. I helped you. I did a good job. But like, I don't need to see you. Right? Your life is good. It's when people's lives are bad that I need to see you. That's when I can help you, right?
So at BMC, let's say, there's so many reasons I think to avoid treatment, and maybe this is a beyond the question, but you know there might be insurance concerns or shame or not having insurance or not wanting to be labeled with a problem. How does the medical system in Massachusetts deal with privacy, HIPAA, and people who are in crises? Like, does BMC turn a patient away if they're in crisis?
So we definitely do not. That's one of the things that I think I love the most about BMC is that like our goal is to take care of everybody. It's exceptional care without exception. So if you show up, I'm going to do my best that I possibly can for you, no matter how crazy or how traumatic the situation might be. In Massachusetts, we have universal health care. There is no reason for people to not be covered. There's a lot of fear about coming into the system, particularly for folks who are maybe undocumented. That's where we see a lot of people being afraid to come in, especially in today's times. Right. So I will say there's a lot of other venues that people can access care that are less medical. So like they're medical light. So if you're not ready to come to the big fancy hospital, check out a needle exchange, right? Go to like an HIV test on one of those vans that does that. Go to like Project Trust is right, like a ground level BMC program for people who are injecting drugs and they do HIV and STI testing. Go there, right? Or go to MGH. They have a clinic in Chelsea in the community health center, right? Lawrence and Lowell have a van that's like a house that they move all the time to do testing. So there's lots of things throughout the state that are medical like. They're not the hospital. So if you're afraid, I would go to one of those things first. And oftentimes you're going to find like peer advocates or peers that are going to be able to help. The other really sort of weird thing about addiction, and compared to every other disease, is because for so long, addiction was siloed. It was this other thing that the medical people didn't deal with, right? Go to your meeting, go to your AA meeting, your 12. Addiction is one of the few diseases where 24 hours a day, you could pick up a phone and call somebody, and somebody going to show up to your house to help you, right? Those sponsors from AA, those sponsors from Narcotics Anonymous, those programs, I mean, they exist and they work for a lot of people, right? And I think we don't do a good enough job of telling people, like, you could go there, right? If you're struggling, go to one of those meetings, find one of the old timers and be like, can you help me? Like, how'd you do this? Who'd you talk to? Who can I talk to? And those are even lower barrier, right? They're like in a church basement or like online. There's a ton of them online right now, which is great.
That's really good advice. So, Justin, what does treatment look like?
I think treatment depends on the presentation of the person. So in terms of treatment of symptoms of meth use, right? Some people can go psychotic from using methamphetamines, like actually psychotic. It usually starts with what's called persecutory delusions, right? So that means people think other folks are out to get them. Now, sometimes that can be really reasonable. It actually sounds really reasonable. This guy comes up to you, he's super skinny, he's a little agitated, he's like, those people were talking about me. You're like, oh, really? What were they saying? They were saying I moved the soda cap. You're like, oh, that doesn't make any sense. And so that's how you sort of know it's true sort of methamphetamine-induced psychosis. The other thing that can happen is people stop sleeping, right? So they're like up 3 or 4 nights in a row, they're not sleeping, they're just using meth, they're just having sex, and that can cause people to go psychotic. And so in any of those scenarios, the goal is to get people to sleep and to treat the psychosis with things like antipsychotics. The other thing that happens, I think, a lot in terms of methamphetamine treatment is there's like programs that we know work, things like contingency management. So in San Francisco, they have this program called the PROP program. So the way it works is it's 12 weeks and you have to give your urine 3 times a week. And every time you come in and you give a urine that's negative for methamphetamine, you get paid. We pay you money. At the end of the week, you get $8.75 if all of your urines were negative for methamphetamine, right? And so this grows with each and every week, but it never gets above $25. And so then by the end of the 12 weeks, people have been abstinent from methamphetamine for 12 weeks, right? And they can start to do some of the therapy and some of the other work that needs to be done to get people to sort of treat their addiction. And so it's a really great break for folks, and we know it works, but it's not reimbursed by insurance. So insurance is not going to say, yeah, you can pay $8.75 to that person to not use meth for a week. Now, if you ask any of the nurses in the emergency room, been kicked or punched or spit at by somebody who was psychotic off of meth, they'd be like, I would pay $875 a week to have this person not use meth, right? But they're not the ones making the decision. The other thing that I think probably we should talk about is the trauma associated with meth, because that is hugely problematic in terms of getting people into recovery.
Okay.
Because it's not just about the trauma people experience, but it's about the trauma people perpetrate. And so oftentimes we see sexual violence is very common in this community because of the hypersexuality. And so folks have either been victims of sexual assault or have been perpetrators of sexual assault and have a really hard time with talking about that and sort of handling that. And that causes people to go back and use more meth, right? It doesn't make you feel better, it makes you feel worse. And meth made me feel better, so I'm going to do that again. One thing that's really hard, and I learned this the hard way in taking care of my patients, is I'm very quick when I take care of a sexual assault victim to sort of characterize their perpetrator as like bad, right? The person who perpetrated your sexual assault, that's a bad person. And then all of my patients were like, but I was that person to somebody else. Right? So then you're in this, as a provider, you're like in this horrible situation of like, well, the person who assaulted you is bad, but you're not bad. Right? And so it really becomes problematic in trying to treat the trauma because patients understand what they did was bad. Right? They don't need me to tell them somebody is bad or not bad. I think actions, especially when fueled by drugs, we see stimulants are the number one thing that people go to jail for, right? Because of the behaviors they exhibit when they're on stimulants, right? It costs over $1 billion to incarcerate these folks. But the treatment really needs to be this trauma type counseling that makes people understand where their trauma came from and how do you cope with it so you don't perpetrate trauma and you don't sort of need to use drugs to get over it.
Layers on layers on layers.
Yeah, but I think that reason though is exactly why providers tap out. This is not easy. People who choose to take care of folks who are using meth, who like are living with HIV and using meth, this is not easy work. And so people tap out because it's too hard. It's too complicated. And folks feel like, and I've felt like this many times, I can't do anything right. No matter what I say, no matter what I do, it's the wrong thing. But my patients kept coming back and keep coming back because I keep trying. I think that's the big thing that folks need to understand when they're seeking treatment too, is I'm here for you and I'm trying to help you and keep coming back. Right? Because I might say something wrong and I'm not going to try to, but I might. And if I do, give me a break. Let's talk about why it was wrong for you. And let's build that relationship so that we can actually help you get to where you want to be.
Mm. So that's really, you're not only treating the patient, you're not just treating the addiction, you're treating the patient. You're doing it's holistic, which is great. So speaking in that holistic vein, for those that live in Boston, we all know the street has another colloquial name, but there's a strip of road on Mass Ave and Melania Cass
Boulevard.
Thank you. Sometimes the mouth, it doesn't work. So let's say I'm driving my car and somebody comes up and they're asking for money. Is there anything else that I could have in my car that you think folks might appreciate or be able to use or not get angry that they weren't handed money?
Candy. I know that sounds, I don't mean that like to be flippant, but I think, sugar, we know when people are in withdrawal actually helps them feel better. And so for some folks, like a hard candy or something that's like wrapped that they know you didn't tamper with can be helpful. But I think the biggest thing people can do sort of to help that situation, this is going to sound very like I'm on a soapbox, but I recently was at a talk by another nurse who said nursing is inherently political. And so people need to vote. People need to vote like the people on that corner are their cousin, uncle, auntie, sister, brother, because they are. Right? And so I think all the time whenever I see people asking for change or stuff, I think like, what would it take for me to be able to do that? What would I have to have in my sort of pride, ego world for me to do that? And that's where that comes from. And I think people need to understand that folks' lives are so hard and so different, and being able to put people in power who understand that, to make decisions about that, to be able to really change the lives for the folks and the patients we serve.
So one of the things that I learned that I found to be fascinating as I've done my work ministering as a sister of perpetual indulgence, I was told by somebody in the community, I happened to have fruit in my car, and so I was like, here, have an apple. And they went, I'm a meth addict. my teeth are falling out. I cannot eat an apple. And I was like, oh, I've got a loaf of bread. Do you want a loaf of bread? They were like, yeah, that's soft. I can have that. So I had never thought to carry soft food with me because, you know, apple is shelf stable.
Right. But I think that's, I mean, those are some of the other like bad things that happen with meth, right? Actually, in that video I referenced earlier, the horrible one by Samsa, not only does the monster steal your soul, it also steals your teeth. Those are the only two things it takes from you: meth, your soul, and your teeth. I mean, it's a horrible video. Please go leave a comment to take it down. I do literally once a month. They still have it up, but I'm going to keep leaving comments because there's so many problems that happen with meth. And by saying just don't even start, it negates the people who already have.
Mm. So you're also an AIDS certified registered nurse. So let's talk briefly about all things testing. So I'm Joe Schmo on the street, and I'm going, I was risky yesterday. Maybe I've gonorrhea, something itches, my nose feels a little weird too. Like, I want to go get a COVID test. I want to go get sexual health screening and an AIDS test. I don't have any money. I don't have any insurance. You've already covered that we have universal care here, but like, what do I do?
So in Massachusetts, you go get tested. But so I think there are sexual health clinics that are still open at BMC, at MGH, and other locations throughout the state that are funded by the Department of Public Health. And what we do a lot is self-collected samples, right? So I can get your rectal swab, your throat swab, your urine sample without coming within 6 feet of you, right? So the only 6-foot interaction we have to have is when I draw your blood, right? And so turn your head, right, and I'll draw your blood and we're good to go. For the COVID test, there are communities that are doing free COVID testing. So many of the HIV community testers have been diverted from doing HIV testing to doing COVID testing. And so we've actually seen a drop in the HIV testing numbers, which I'm concerned about. But we've seen 200 to 300 to 400 people in some communities getting tested every day for COVID in these like mobile health models. And so when you only have so many public health dollars, right, they can only go so far. So this is again why I say we need to vote and get people who understand we need more public health dollars, because then we could do both things, right? We could chew bubblegum and walk at the same time.
That's a very important thing that you just said, because in my mind, before you even got to before you said public health dollars, and I went, oh, I was like, why don't we just have the rapid test for both? And they're like, prick your finger, like, and tap, and then we'll wait 15 minutes and see.
That would be lovely, but that technology does not exist yet for COVID, so.
Does it not? Is there not a rapid COVID test?
So there is a rapid COVID test, but it's not a simple prick your finger and we find out. It's still a swab. Yeah.
Have you had one?
Have I had a COVID test? Yes, and I've done those swabs for years on patients.
Not that bad. They're nothing to be afraid of.
No, and I mean, people need to know it's gonna gag you, right? Like, and I used to tell patients all the time, I'm gonna put this down your nose until you gag. If you didn't gag, I didn't do it right. I'm sorry. And I think that setting the stage for people, it's not painful usually, it's just uncomfortable.
Right. So don't let any of that scare any of you away if you're watching right now and you're like, I really need to go get a test, but I'm scared. Let me tell you, I've had to. I'm sure Justin gets tested frequently since he's in the healthcare system. So please don't be afraid. And the resources are, you can go on to the Google machine and type mass COVID testing, and you will get a city website. In fact, it's a map of the state with different color coded, like, is it a health center? Is it a pop-up? Is it a blank? You can drive up in your car. You can walk up. There are so many options that will fit your need. And Justin was saying you can also self-swab, which I think is really great. You'll be separated by a divider, plexiglass divider, and the practitioner will be on the other side going, nope, you're gonna have to a little bit further.
I haven't seen anyone do a COVID self-swab yet. That I was talking about like your rectal swab and your throat swab.
I did a COVID self-swab at Codman Health Center at Ashmont.
That's great. That's awesome.
Yeah, outside Ashmont Grill, they set up a community. You walked into one lane, filled out a form, and then it was 3 nurses that like kind of back to back, like circled the wagons, and each had a plexiglass booth. And
love it. I love self-swabbing. I think people know, right? We got into these situations because people know how to put things in places. So
right, and so it takes away to like when I do it myself, I suddenly, not that I have inherent, I really don't have shame. I practice the shame.
You never.
There's no room for that. But when you're empowered to take your health into your own hands, I think that's magic. I think that's really amazing. Do you want to tell us what the Ryan White program is? I think you're on are you on the board? Are you the president? Are you the vice board?
No, I sit on the Ryan White Planning Council. So Ryan White is a program that funds HIV and AIDS services. They're the payer of last resort for HIV services in the Commonwealth and throughout the country. In Boston, we actually have an EMA, right? So it goes from southern Massachusetts all the way to Worcester, all the way actually up into New Hampshire. So the lower counties of New Hampshire and the Boston EMA. And I am really fortunate to sit on the planning council with some amazing both consumers, so some folks who live with HIV, some providers who provide services, and then just really vested community members. And it's a great team, and we get to help decide how those HIV dollars get spent, right? And so it's fun because you like have worked in the field for a long time, and you get to finally have like some say in like how those monies get spent. So if somebody is living with HIV or really vested in that, I encourage you to like come check out Ryan White. You can apply, you can be on the board, you can be on the planning council. And it's really cool. We have a good time. We always have fun while we do it. But we meet multiple times a month, and it's interesting, fun, good work, good people.
So Justin, I want to thank you for spending the last hour and change with us. And before we depart, is there anything else that you could think of that our viewers might find empowering or important to hear, specifically during the circumstances that we collectively find ourselves under right now?
So this is totally an aside, but my favorite author is John Steinbeck. And John Steinbeck had this saying that he used to use all the time called ad astra alia porci, which literally means to the stars and the wings of the pig. And I love that sentiment because I think that is, in essence, what we all are. We're all this like lumbering soul, just trying to fly, like trying to figure it out. And I think when I come to my work and what I do is I see everybody as that lumbering soul trying to figure out who they are and how they're going to exist in the world and be better. I think that's where we're at right now, unfortunately, with COVID. We're like this lumbering soul trying to figure it out. Nobody really knows the right answer. And so I just say, like, be patient with yourself and know that there's people out there trying to help.
That's great. To dovetail into that, I've definitely noticed across my Facebook friends an uptick in depressive language and or even worse, self-harm language. It's really on an upswing. So know that there are resources out there. There are caring practitioners like Justin ready to catch you at a hospital. You've got the sisters you can call. Literally so many people. So none of you are alone. And if you're suffering right now, you do not have to be suffering. And there are trained professionals who can help you get to the other side. So when you're ready, just ask for help. There's no shame in it.
Come on over.
So Justin, thank you again for spending the evening with us. And please stay safe out there and keep doing this amazing life-sustaining work. And a huge shout out to Boston Medical Center. Exceptional care without exception, resilient.
Thank you so much. I appreciate it.
Everybody have a great night. Bye.